Welcome back to Investigator Insights, looking at the CMET receptor, targeting this receptor as a therapeutic strategy for cancer. In the first session, we talked about some of the science of the hepatocyte growth factor ligand and the CMET receptor tyrosine kinase. And so now we're going to look at some of the early clinical data, the phase 1 and phase 2 trials, and identify some of the novel agents that are emerging as potential clinical agents in the future. So, David, let me go back to you first. Oh, I forgot David Spige, Johanna Bendell, both from the Sarah Cannon Research Institute. So, what about the mechanisms for targeting CMET and its receptor? We talked a little bit about tuvantinib as a tyrosine kinase inhibitor. What type of targeting mechanisms are being looked at coming out of pharmaceutical companies and research labs?
I think so far the development plan has paralleled what's happened in other receptor tyrosine kinase pathways. So you can target the ligand, in this case HGF or scatter factor. You could target the receptor itself on the external domain, the extracellular domain, or you can target the intracellular domain with small molecule inhibitors. And that's where we're at right now. So several monoclonal antibodies have been developed that do just that serve as drugs that focus on the ligand. And of course, more recently, some activity of focusing on the receptor itself. And then, as Johanna was alluding to, several actually small molecule inhibitors in development. Some we've already gotten results on, and some we're waiting on results. But those are the main mechanisms, though there are other drugs, peptide inhibitors, that potentially are also in development. One of the dilemmas, I think, with the antibody development, at least initially, was agonist activity. So that actually some of the early attempts with drug development were the development of antibodies that linked to the receptor. So they did the job well at binding the receptor, blocking ligand binding and stimulation, but the actual binding of the antibody to the receptor caused agonist activity. And so
they cause dimerization and activation.
And of course, that's not the direction you want to go. And so, one of the struggles has been, how do you overcome that in your drug design, your antibody design? And one drug we'll talk about from Genentech Roche has tried to overcome that with its unique one-arm design. What's interesting is one of the drugs Johanna was alluding to, rilotumumab. My understanding is early on, actually, there was some concerns about this agonist activity, and yet this is the drug that's showing promise in gastric cancer. So maybe what's seen in the lab doesn't really translate to anything clinically meaningful. So that's where we're at right now, and certainly many drugs at different stages of development in lung cancer. There's been some excitement, I guess, with two drugs in that they've made it to phase 3 trials, and one of those phase 3 trials has closed early, so we know results already from that trial. So maybe we'll talk about that first. That was tuvantinib.
And tuvantinib is a fairly selective CMET inhibitor?
So this is where I think there's always some debate here about how good of a CMET inhibitor is this drug, because we know that there are other targets for this compound. In fact, I think sometimes unfairly this drug gets labeled as a bad CMET inhibitor because its other targets may be more relevant in its anti-tumor efficacy. But I think there's enough preclinical data to suggest that there is inhibition of the MET pathway with this drug. That was reasonable enough to explore this in lung cancer. And Johanna, can certainly get into some of the GI data, but to walk you through this, basically this drug was first studied, it's an oral medication, this drug was first studied in a randomized phase 2 fashion in a patient population of non-small cell lung cancer that had already received first-line chemotherapy. So the same patient population in BR21, right, where erlotinib Tarceva was compared with nothing, supportive care. So in this randomized phase 2 study, patients received erlotinib in both arms, but one arm received tuvantinib with that. And it was a trial that was designed to look at an improvement in progression-free survival.
Hoping to block two receptors.
Right, so yeah, and I apologize I didn't get into that, but you alluded to these, the crosstalk. Johanna was talking about the importance of crosstalk and heterodimerization with other pathways, specifically EGFR. So there's known interaction with EGFR, and something we didn't touch on is some groups, in particular the Mass General group, Jeff Engelman's group, was the first group to help show us that activation of the MET pathway could be a mechanism of resistance for patients who had initially responded to EGFR tyrosine kinase inhibitors like erlotinib and gefitinib. So if you're on a drug like erlotinib and ultimately that drug stops working for you, MET could be one explanation for why that patient developed resistance. There's been some debate as to how frequent that is. I think in Jeff's original publication, it was thought maybe that was 20% of all resistance mechanisms. I think that number is probably lower in today's view, but certainly it's one mechanism of resistance. So there's rationale to combine a MET inhibitor with erlotinib. So to cut to the chase, in this trial, there was a suggestion of some advantage in a subset of patients in this study. So the patient enrolled patients with squamous tumors and non-squamous tumors. In the non-squamous subset, there was an advantage in favor of the combination versus erlotinib alone. That did not translate into an overall survival advantage, however. There was also some subset suggestions in KRAS mutants, so in patients with KRAS mutations, but the numbers are very small. Actually, all these subsets in a randomized phase 2 study get problematic, right, because they get very small.
And KRAS mutation is a fairly common abnormality in non-squamous carcinoma.
That's right. It's something we expect in at least 20 to 30% of our patients to have a KRAS mutation. So this was enough to prompt a phase 3 trial, to move forward and say, okay, can we look at this and go after overall survival? Can we take patients, in this case with adenocarcinoma, so to focus the population, and expose them to erlotinib and tuvantinib or erlotinib alone? So that trial was conducted globally. Actually, our center participated in that study. It was led by Giorgio Scagliotti and Alan Sandler. And that trial enrolled quite well. I think it speaks to some of the popularity of this idea of a new drug, a new target.
This is the marquee?
This is the marquee study. And unfortunately, in the last few months, the trial finished enrollment, but a press release was issued that the Data Safety Monitoring Board had conducted an interim review, and it was felt that this trial could not achieve statistical significance in favor of the combination, so the trial was stopped. We're still waiting on the data. All we have is the press release. There did not seem to be any major safety issues, at least that was released in that format. I expect in the next several months at our major meetings, we're going to hear more about actually what was shown. Let me just finish with tuvantinib and say that there's ongoing work. There's a randomized phase 2 study led out of UT Southwestern looking at this similar combination in patients with KRAS mutations. So there's still hope, so to speak, for this compound in lung cancer, but it may be in select subsets.
So was the population in the marquee trial stratified for CMET amplification or overexpression, so that with subset analysis we might find if there's a population there that benefited more than others?
So, and I apologize, as I recall, there was certainly stratification in this trial. I believe it was for EGFR mutation status and by performance status and prior line of therapy, but I don't recall MET status as a stratification factor. Tissue was requested for this trial, and there are plans to look at MET signaling by all of these capacities to measure it, so by immunohistochemistry, amplification, and mutation status. So we await those subset data, but no, you did not get chosen to go on Arm A or Arm B based on your MET expression status.
Yeah. So the primary endpoint, overall survival, was not positive, but we may yet get some interesting data out of that trial.
Yeah, I mean, all we know is that had the trial proceeded, it would not ever achieve the statistical boundary for overall overall survival significance. But no numbers have been released, so we don't know that yet.
For sure. All right. Well, Johanna, let's talk a little bit about the monoclonal antibodies. David mentioned rilotumumab and the onartuzumab, difficult drug to pronounce. What is the story with those agents in the GI malignancies?
So rilotumumab is a drug that binds to HGF. So just like bevacizumab binds to VEGF to prevent it from binding to the receptor to activate it, rilotumumab binds to HGF to prevent it from binding to CMET to activate it. And so we saw...
So it's almost like VEGF trap in that way.
Exactly, it'll bind to that ligand.
Sucks up the ligand.
Exactly. And so what we saw from a randomized phase 2 study of patients with metastatic gastroesophageal cancer, first line, and they were randomized to chemotherapy plus or minus rilotumumab. Now again, just as David was saying, these are small numbers of patients, but what was very interesting is in the overall intent to treat population, there seemed to be a trend towards improved progression-free survival as well as overall survival, treating with rilotumumab plus chemotherapy versus chemotherapy alone. What was even more interesting is when they broke it down into the MET high patients, so the IHC overexpressors, they seemed to have a more pronounced effect of improvement in progression-free survival and overall survival. And so then this study will now be taken into phase 3, looking at chemotherapy plus or minus rilotumumab in this population. The other antibody that we're looking at is, so the way that I remember it is one-arm-tuzumab. So onartuzumab, the one-armed man from The Fugitive. This is all I can think about. So this is also known as METMAB. And so this molecule has been looked at, is now being currently looked at in the gastric cancer population as well. So that's involved in a randomized phase 2 and randomized phase 3 study that has just started in Europe of chemotherapy using FOLFOX as a backbone plus or minus onartuzumab for patients with first-line metastatic gastroesophageal cancers. Onartuzumab has also been looked at in non-small cell lung cancer, and I'll let David talk about that since he was the lead of the randomized phase 2 study in combination with erlotinib. But within colon cancer, we've been looking at it in the first-line setting. So we've seen a lot of trying to play on the interaction of the CMET receptor with other receptors such as EGFR. And this is trying to play on the interaction of angiogenesis and VEGF. And so the study was known as the ACCOMPLISH study, a randomized phase 2 study of FOLFOX bevacizumab plus or minus onartuzumab for patients with metastatic colorectal cancer. In this study, there was no stratification to MET status just because, again, even though we're seeing this trend towards improvement in outcomes in the CMET high population, we're still not sure that per tumor that story is going to be the same because there's different methods of activation, there's different staining patterns. And so we did capture MET status for the colorectal cancer patients, and we're seeing about 40% of colorectal cancer patients are MET high. We also know that in colorectal cancer, as well as multiple other cancers, overexpression of CMET's associated with a poorer prognosis and a more aggressive cancer. So we're hopefully going to see data from that study probably later this year, sometime later this year to read out. We've also looked at rilotumumab in colon cancer, and this is a small randomized phase 2 study that looked at panitumumab versus panitumumab plus rilotumumab versus panitumumab plus AMG 479, which is an IGFR inhibitor. I'll just sort of toss that last arm out right now because we didn't see any clinical signals from the IGFR inhibitor combination. But when you look at the panitumumab and the rilotumumab plus panitumumab data, the initial comparison was looking at response rate. And in panitumumab alone, for KRAS wild-type patients, it was 20%. And in the patients who got panitumumab plus rilotumumab, it was 30%. So a suggested improvement in response rate. The progression-free survival data, though what's been presented has been early, seems to show a slight improvement in progression-free survival. And so this trial will continue on to look at panitumumab versus panitumumab plus rilotumumab.
Very good. So the expression of the CMET receptor seems to be an important factor. What about expression of the ligand? Do patients with higher than usual levels of HGF do better with relatubumab, or do worse, or do we know anything about that yet?
We don't. And so this is an active area of investigation. People are taking blood samples within these studies to look at levels of HGF as well as HGF activating factor, that enzyme that cleaves HGF to activate it. And so that might be associated with outcomes as well.
And does KRAS status seem to play a role at all?
Right now, we're unsure. So the studies that have been done in, for instance, colon cancer have been in the KRAS wild-type population where they're combining it with panitumumab. We've also seen a study, a randomized phase 2 of cetuximab plus irinotecan plus or minus tivantinib. And so far, we don't know that KRAS story within colorectal cancer.
Very good. Okay, thanks, Johanna. So David, Johanna gave you a segue into the one-arm tuzumab in lung cancer and METMAB. And I know a couple years ago at ASCO there was some data in non-small cell lung cancer with METMAB. Tell us that story and how things are proceeding with that agent in non-small cell.
Yeah, sure. I think this has been an interesting story so far, but I'm quick to say we're waiting on more mature results. I think the story of onartuzumab, or METMAB, I think is commonly referred to, starts with a phase 1 trial that was conducted by Ravi Salgia out of the University of Chicago. Interesting trial. It was for patients with refractory tumors where they got onartuzumab alone, and there was another cohort which Johanna knows about where they combined that with bevacizumab. We don't hear much about that. What's interesting about that phase 1 experience is that there was one patient with gastric cancer who had an unbelievable response, actually a complete response, and it didn't come early. The complete response came later. Now, as Johanna has already well described, gastric cancer seems to be a great tumor type to use these anti-MET therapies, and it's probably because of this autocrine loop, this overproduction of HGF in that tumor type. But that was a nice signal there to help in this drug's development. There have been preclinical studies that suggest if you take cell lines that are sensitive to drugs like erlotinib and you expose those cell lines to things like HGF, the sensitivity is lost. The erlotinib sensitivity is lost, and you can restore that sensitivity in the presence of a drug like METMAB or onartuzumab. So there was some rationale to combine METMAB or onartuzumab with erlotinib. So what was done was a randomized phase 2 trial was conducted. It was run actually a global study that we participated in, very similar to the Arcule or tivantinib phase 2 experience. So this was patients who normally would get erlotinib, patients in the second and third line setting. They weren't enrolled on this trial based on their MET status. I'll get to that in a moment. It was the typical enrollment criteria for patients who had 1 or 2 prior lines of systemic therapy, regardless of non-small cell histology. And the randomization was pretty simple. It was erlotinib alone or erlotinib and onartuzumab, which is, we didn't say this, is given intravenously every 3 weeks. Although in the colorectal trial, I think the dosing was different. This trial was designed to look at 2 primary endpoints, so both for progression-free survival. One was in the overall intent to treat population, and then one was in a predefined MET positive or MET high population. And so let me take a moment to talk about that, because that's an interesting story in 2 ways. One is was a good example of the importance of collecting tissue. So in this randomized phase 2 study, every patient had to have sufficient tissue for this analysis. You didn't have to know the results of that to get onto this study, but you had to have enough tissue. So this is a little commentary on phase 2 studies, certainly that can be done in the community, where you can ask your pathologist and require them to check off, so to speak, that yes, Mrs. Smith or Mr. Williams has enough tissue for enrollment on this trial. And that extra kind of nuisance, Johanna and I we cringe sometimes. We think about things that make our trials more complex, but that extra complexity is what made this trial interesting. So what happened was every patient sample was assessed for a number of things, including MET status by immunohistochemistry, but also KRAS and EGFR mutation status. There were actually some other correlative studies performed as well. Before the data were unblinded, patients were scored based on their MET status, and it was anticipated that about half of the patients would be MET high and half would be MET low, so to speak. The MET high group was a group of patients who had 2+ or 3+ tumors by IHC and at least 50% of the tumor cells. As it turned out, about 50%, it was 52% of patients had MET high tumors. So that was very helpful for a small study where the numbers worked out almost as an even split. To cut to the chase, there was no real advantage for things like response rate. But for progression-free survival, in the MET high defined group, there was an advantage for PFS. And that translated, surprisingly, into an OS, overall survival advantage. Now what's interesting is in the overall intent to treat group, there was no split of the curves. They sit right on top of each other. So when you look at the MET low group, because they were enrolled in this trial as well, there was actually a disadvantage to getting onartuzumab and erlotinib. So they did worse, which explains why the overall intent to treat group matched up. One group MET high did well, and one group MET low did worse. And of course, they met in the middle when you combine the results. The MET high data set is what has prompted a pivotal randomized phase 3 study that's in progress right now. So that trial, which has been underway globally, is a trial where, yes, you need to have refractory second, third line non-small cell lung cancer, but the difference here is you need to have MET high expression.
Very good. Well, we'll get into more details on those phase 3 trials in the next segment. So this has been very interesting. A lot of very intriguing data coming out of these early trials, and it's going to be very interesting to see what happens with the ongoing phase 2 trials and the phase 3 trials that we'll talk about in the next segment. So thank you both very much for this, and we'll conclude this session, and we'll move on in a few minutes to part 3 and talk about the phase 3 data and some of the other novel agents that are in early trials. Thanks so much.